Folks, thanks for joining us today. My name is John Dubas with Premier Marketing, and we'll be spending the next hour or so discussing one of the programs that's of great value, not only to the beneficiaries that we serve, but also to ourselves and our agencies. And that's working with the specialized program in the Medicare Advantage arena, namely a dual special needs program. We have a special guest on today to help us with this discussion. But we look to make certain that we get you the detail you need to help us help people with these programs. Specifically, we have guests from Molina on to visit with us with their viewpoints on the eligibility of these programs and a brief overview on a national basis of the offerings that they have for us as agents working in this area. Today's presentation is being recorded and will be made available on our website at premiersmi.com and on our YouTube channel as well. So have that available for you as soon as it will upload. And the software system has a section for both questions and chat. We ask that you put your questions in the questions box. We find that we answer most of them through the course of the presentation, but we want to make certain you get the detail you need to extract full value out of today's presentation. We want your return on the investment of your time to be as great as possible. The presentation is aimed at agents of varying experience in this area. So for some of you, some of this might be remedial, some it might be a welcome review, and for others, it might be brand new to you. So we want to make certain that we have a level set on the different programs that are affecting this type of offering to the Medicare beneficiaries. And it starts with a little bit of level set about who Premier is. We're a national marketing organization founded in 1968 that's part of the Integrity Marketing Platform. We're licensed in all 50 states, acting as an insurance wholesaler through independent insurance agents such as yourself, through contracts that are at the highest possible commission levels, with recruiting contracts available to those who qualify. And we do so through a full portfolio of products, including the base medical programs that take care of the Medicare population, including Medicare Advantage plans, including special needs plans, such as what we'll discuss today, but also Medicare supplement programs and Part D prescription drug plans, standalone PDP programs. Additionally, we offer a full portfolio of life insurance and annuity products, including final expense life insurance, pre-need plans, long and short-term care programs, disability income plans, and ancillary benefits that take care of specific needs that are part and parcel to the lifestyle needs of the people we serve, the beneficiaries looking for coverages in those specific areas. When we look at Medicare Advantage, we have the national carriers available through our organization, including strong regionals as well, and obviously our guests today with Molina fall into this category. When we look at prescription drug programs, it's fairly similar philosophy as the Medicare Advantage plans because, well, most of these come as part of that contract with a Medicare Advantage carrier. A couple of exceptions. Mutual of Omaha is a PDP program separate from their other offerings, and Clever RX is actually a discount program and not a Part D prescription drug plan. When we look at Medicare supplements, because we want to address the needs of the entire Medicare population, we have a broad portfolio in play there as well, and specific programs to help you be successful in this space should you choose to pursue it. We look at ancillary benefits in each of those categories. The national leaders are there for you. We do this for a number of reasons. Obviously, we want to take care of the needs of our prospects and clients, but we also want some marketing flexibility and a creation of additional revenue streams into your agencies as well. We look at the Medicare market overall. You don't come on a program like this without hearing of the aging of the baby boomers, the silver tsunami, one every 10 seconds, 10,000 plus a day. And that's the way it works if you look at Medicare based just on turning 65 individuals. What we have, however, is a number of those folks that are delaying accessing their full benefits through Medicare for one reason or another. They may be continuing to work or whatever the circumstance may be, but we also have that number more than made up for by the portion of folks on Medicare because of disability under the age of 65. And these are folks that are prime candidates for the programs we offer in the Medicare arena, specifically when you speak of dual special needs plans, because many of them, because of the disability, are also disadvantaged when it comes to their pocketbook. And so we want to make certain that we can address those needs as completely as possible as well. Because when someone comes on Medicare, they got choices. They don't have to do anything. They can decline the Part B should they choose to do so. Thankfully, most don't. There are some that do because of special circumstances and it's in their best interest. But some folks will then insure for the shortfall in the standardized traditional Medicare programs, maybe pick up that standalone Part D to help with prescription drug plans, or some may take out a standardized, modernized Medicare supplement to take care of those bills that are crop up with medical circumstances under Medicare. Some bundle all together under the Medicare Advantage plans, the all-in-one programs as we hear on television. Our topic today falls in this category. We do a thorough examination of these programs simply because that thorough examination may not be happening with the Medicare beneficiaries that you visit with. You can see in this graphic from Kaiser Family Foundation, the vast majority of people on Medicare don't examine their plans during open enrollment year over year, which is a challenge. But because of the special circumstances that we have with dual special needs plans and the special election periods that they can create and take advantage of, we can address this population that didn't do their due diligence in the annual election period that recently ended. So we have a grand marketing opportunity with these programs as well. And that carries over to the folks that don't have any other coverage other than traditional Medicare. They may be unaware of eligibility or how to go about enrolling or whatever the circumstance will be. But regardless of their base program, we have an opportunity to help them. And many of these folks haven't looked into additional coverages. And frankly, there may be people that are on standard Medicare Advantage prescription drug plans that qualify for and would be better served by enrollment in a dual special needs plan. So something we need to be aware of and work with in our marketing programs. And we want to make certain too that we discuss these programs in a manner that is easily understood by the population we're addressing. And that includes then making certain that we limit our use of acronyms, but communicate with the ones that are basically unavoidable. So we want to make certain that we can tell people what these things mean. And when we deal with the dual special needs programs, the education level tends to be a little lower than some of the other areas. And so we want to make certain that they understand what we are addressing and how we're going about doing it. And look at that, 4,420 acronyms on this slide from the CMS website. There's a lot to understand. And folks aren't using the tools that are put out there by the government. So all these different resources, the toll-free number, the website, the Medicare and You book that's sent electronically or by mail, the programs that are available for smartphones from the App Store and Google Play, or even the recordings that are on the internet put there by the government. And I got to tell you, some of these are pretty good. They're not being used. And so we need to make certain that we can deliver information to this population in the manner in which they can digest it and understand and move forward with the information they need to make the best choice for themselves. With the population we speak to in the dual community, well, some of that may be more in-person work than some of the other areas that we work with Medicare Advantage plans or MedSups PDP programs. But there are folks that still can then pull in the information virtually. And of course, that portion of the population, that is kind of a hybrid where we work both systems to make certain that folks understand the information that we need to deliver in order to stay compliant and educate the population on choices they have available. And the systems themselves, well, we've had over 3 years of education forced upon all of us, basically, by the pandemic and circumstances. The population that are eligible for the dual plans are becoming increasingly digitally savvy. They are having greater access to the tools they need to pull this information on an electronic basis, make it available to them. But keep in mind some of the things that we need to do to stay compliant with the scope of appointment, recording calls, things of that nature. We need to make certain that we help folks understand why we're doing what we're doing, and that they have the capability of accepting the information and understanding it. We just came out of the annual election period not too terribly long ago, and we have seen through the Kaiser Family Foundation slide that we had a little bit ago that a whole lot of folks aren't taking advantage of that opportunity to investigate and perhaps change coverages. But we have then, of course, the OEP coming up the first 3 months of the year, which we can't really market, but gives us an opportunity to switch from one MA plan to another type of situation. Reference back a webinar we did on special election periods last week to get some full detail on how that works. But we have special election periods that allow us to address the needs of the populations we speak with in the Medicare community throughout the year. These 20 SEPs, acronym in play there, special election periods, many of them deal with dollars or lack of, or changes in that situation, or eligibility for a special needs plan even. That gives us an opportunity to help these people all year round. The frequency of that special election period may have changed from a few years ago where we could do it monthly. Now it's a quarterly situation, but we take that into account with some of the special election periods that are influenced by weather or other circumstances. Hey, here in Texas, we even got a special election period for drought. Carriers help us understand these opportunities we have and how they can help us address the population that needs this assistance. But keep in mind, some of these don't allow us to market specifically to them, but we can still take advantage of the situation and help people with their coverages moving forward. So as we speak to the topic of today of working with dual special needs plans, we have the opportunity once again, because of the special election period, to help people throughout the year. And we have a number of strong carrier partners that can help us in this area. And one of those that we highlight today is Molina. So we have a couple of guests on with us today. We have Joe Lukasik and Jim Spencer on to help us walk through some of the systems, the requirements for these programs, and the things that can happen in conjunction with working with this population, with working with a strong carrier such as Molina. So without further ado, I'm going to ask our guest to help me out and work through this system, and then we'll come back and visit with you toward the end. So here we go.
I'll take it. Joe, you want to kind of introduce us while I get make sure we get the screen showing right and everything?
Yeah, so I mean, just kind of a quick little intro here myself. My name is Joe Lukasik. I am part of the national account team here at Molina. I work with Premier directly and their downline agencies and agents kind of thing. My job is to help you guys if there's questions about the plans, if there's interesting new markets that we're trying to expand into. Essentially, short version is, your success is my success. So whatever I can do to help get you onboarded, get you more comfortable with Molina, if it's training, one-on-ones, if there's, potential disruption that, we can maybe take advantage of. End of the day, like I said, I just like to try and take care of folks here. And my boss, the illustrious Jim Spencer, been with Molina for many years. He is going to be kind of driving the bus here for this presentation about low-income Medicaid, kind of going over some of the basics and then some of the details of the different election periods and the differences between LIS1 and Medicaid QMB versus, all those acronyms that John was just talking about there that I'm sure I broke about 15 rules. So, but I'll hand it off to Mr. Spencer here and let him take my foot out of my mouth for me.
No, it's excellent. I think, John, thank you for the opportunity. Joe, thanks for setting us up to help everybody understand on the call. Want to make sure two things are working before I dive into this, because we got a lot of information to cover today. I'm gonna tailor it to the time we have, trying to keep us within our time slot here. But I'd love to be able to take questions as we go. I've learned with this presentation, as I go around the country sharing this, that there's always a lot of specific nuances between all the different programs for people who have low income and what they can do to help pay for their medical expenses. Obviously, there's a handful of options that we all get thrown into one lump, and today I'm going to break those out and help you understand them. But before we do that, I want to make sure you can see my screen okay, because there are some of the graphics that do help illustrate this and help you understand the points. We do go through, as John was alluding to, a lot of acronyms today. We really dive into Medicare's alphabet soup to the deepest level today, because we're going to talk about those Medicare savings plans that some of you, if you've only ever really been oriented to this on AHIP, this is all of those QMBs, SLMBs, QIs, QDWIs, all of that part of the alphabet soup on top of our part A, B, C, D, and plans A, B, C, D, E, F, G, on down. CMS sure loves to make things confusing, I think, to the average person, and we're going to hopefully create some clarity. So one, if you can see my screen, and I need you to open the chat window so that you can send questions, and I'll just take them as they come in and try to address them and let you know if I'm going to cover them a little bit later, or I'll even back up. So if everyone, plus after the COVID years, we all are great multitaskers. So this is my tricky way as a presenter getting feedback from you. But send me a quick note in the chat, just saying, hey, you can see your screen, fine, hear you fine, let's get moving. Or just say, hey, I'm here, see your screen. So send a few of those in the chat so we can see who all's out there, and that we got all the pieces working together for you. So we'll watch for that. But let me dive into some general stuff while we watch for your chat messages to come in that help here. Today we're going to step through a number of options for low income. First thing I always try to cover a little bit when we present is just to remind you who Molina is, because the Molina is new to some people in some areas. We're also where we are not one of the big national advertisers. A lot of people are surprised to find out that we are a Fortune 500 company. Matter of fact, we're number 140 or no 125 this with one of the last reports. We've been in the business for 40 plus years. We really are a Medicaid and Medicare specialist. We also are Texas and several other states marketplace largest providers. We really do focus on government programs. So Medicare, Medicaid, and ACA type stuff is exactly our niche. We don't get into the commercial insurance business. So because that, we don't do the big advertisings. You won't see a whole lot of sitcom stars or former athletes advertising Molina. So I always like to give you a little background on us. But we've been around for a lot of years. The company went through some major changes about 5 years ago. And we've just been super excited that part of those changes was a complete whitewash of our senior executive team. The board of directors came in and really made a change. And if any of you have watched our stock, I'll just leave it at that. Go check out our stock the last 5 years. And hopefully you got in back when we were $25, $30 a share, because we trade about $350 a share now, and have done quite a few acquisitions in our growth strategy as we continue to expand service areas. So lots going on with Molina. Like I say, much bigger organization, but we really are this low income specialist. And today I want to dive into some of the ideas of low income, but I want to start out by building a little common ground. And the common ground with all of our thinking is a little bit, I really appreciated John's intro today. He really hit on a number of points I'm going to put a little more emphasis on and maybe a little detail around, but I'm not going to spend as much time on where he's already given you a little introduction on it. So to get some common ground, everybody always wants to kind of understand, there's three different, or it helps to understand, there's kind of three different ways to do your Medicare, right? And each one has a different unique population to go to. And one of the questions we often get right out of the gates is, can someone who's on Medicaid, can they do traditional Medicare? Can they do fee-for-service Medicare? And the answer is yes. Can they join a normal MAPD, or what I call a traditional MAPD plan? And the answer is yes. Do they have to be on a D-SNP or other special needs plan like an I-SNP or a C-SNP? And the answer is no. Now, most states like them there because there's additional funding. And if we look here at this diagram, what I'm hoping to do is establish some common ground with you, because I know when I own my agency and my business and with my agents, we sold a lot of SUPs and PDP plans, and we sold We were about a 50-50 agency given the clientele we had, and we did about 50% MA plans. But both of those had kind of a unique niche. The fee-for-service, good old traditional Medicare with PDPs and SUPs, were often people who had higher monthly incomes that could afford the rising SUP price and knowing it, but wanted the security. They may have had more health issues because they wanted the security to know that everything was covered except their Part B. Of course, I was selling back in the Plan F days as well, but the plan with Plan G, knowing that their Part B deductible was all they had to cover. It gives a lot of security to people who can do that, and that still represents over 50% nationally. Each state now is getting awful close, and some states are flip-flopping and going more towards Medicare Advantage plans. But it's a different little population of our seniors mostly here, right? Because they then can, the seniors can shift and look at Medicare Advantage, and where my agency was a big second home retirement area for people from the New England and from the West Coasts. Both would come and like the dry humidity of St. George, Utah, just about an hour and a half north of Vegas. And we'd have a lot of people in who really, they either had lower incomes or just better health and didn't want to have to pay for their insurance and didn't want to get a penalty, so they'd pick up a $0 MA plan. But also people with low income, that $0 plan makes a lot of, makes a little more interesting for them, but they still have to pick up all the costs of their co-pays and co-insurance. But the cool thing there is we all know all of you who've sold Medicare, is that the additional benefits really have been the thing that pull people over to a Medicare Advantage plan. And those additional benefits, with the four big basics always, the fitness, dental, vision, and hearing, really have been the battleground of sales. Dental's been the big battleground nationwide the last few years of the benefits and them dramatically changing of how people administer their benefits. And we've been thrilled at Molina to be one of the first to introduce the idea of a dental benefit on a MasterCard, a Flex card, where it's dollars given to them to spend any place they want as cash, and not have to deal with pre-authorizations or networks or anything that way. But those additional benefits really do make the battleground between fee-for-service and original Medicare or Medicare Advantage plan. The big thing that most people aren't as familiar with, and hopefully we're going to cover today, is this third category. These special needs plans that got introduced back in 2009 by CMS and the federal government of additional funding for people who have certain situations where their medical expenses may be increased or may be larger than an average person outside of that. And so these special needs plans came in. Chronic plans, obviously, for people who have specific chronic plans, have better coverage to cover that chronic condition. Institutional special needs plans are for people who are usually in a long-term care or a facility that they're there for an indeterminate amount of time, and they administer meds and all those things that classify as an institution. And they are special plans that are geared, and the benefits get adjusted to both of those. Now, as Molina, where we deal with government programs, we do offer both of those type of plans in unique situations in parts of the states. But the place that we've really become known as one of the industry's experts and leading people is in the dual special needs plans. A lot of that's because of our Medicaid roots. We really come from a place of understanding the people with low income and how they come, and so that lowest income opportunity comes. Now, a lot of people have low income, and it's related to their health. The reason that their income is bad is they're either dealing with some type of physical or mental disability. They may be dealing with, or a handicap of some sort there. They may be dealing with drug addiction, behavioral health issues that are, subsequent of just, crisis in life, or PTS if they've, served for our armed services or anyway, but they usually have the worst health. And so there's additional federal funding that gets added to the state level funding of matching up these people and in their special programs for them to help them be able to get the medical help they need. And that's one thing to really look at as we talk about this today, is that this is really a vulnerable population that both CMS and your state governments really watch like a hawk, right? That's why we've seen the last few years the legislation changed at CMS that we can no longer have look-alike plans, because they have had so many complaints that those were deceptive. And that people were selling them as if they'd have zero costs, and they let their Medicaid drop, and all of a sudden they don't have a secondary payer, and those look-alike plans were really 80-20 plans, and fee-for-service, not much better than fee-for-service Medicare with just a few additional benefits. But that additional funding allows us to have even richer and a much larger list of additional benefits on these special needs plans geared to this audience. So we're one of the strange insurance companies that come to you and say, get your clients to use their policies, spend that money, get it used, because we can't make any more profit. We're all regulated that way, but we do bring in that additional funding and we're able to pass it on down. So you're going to see the differences between those groups. And as you go sell and as people fit these needs, it's typically by far a better solution for you to understand this whole space and help them. And to add to a little bit of what John was saying earlier is that not only does this group might need a little more hand holding when you're visiting with them, one, because they're a targeted group. They're very defensive. They really lurk off trusted sources. But if you flip that coin over, that's one of the best things you can do to grow your business, because they talk among themselves. They socialize together at the food banks. They socialize together at the clinics. They socialize and they share ideas. And if you gain trust with one, you'll usually get 10 or 20 referrals. And who doesn't like referrals calling in, right? They talk among themselves. They're a self-rep, and back in my years, I owned an ad agency and we did a lot of profiling of markets. This is a self-referencing community. They reference among themselves. And as you get a reputation there, you can really grow a business here. So it works really well. But it really is the joining of people who are Medicare and Medicaid, right? That's the dual aspect of dual special needs. They're dual eligible is the technical term of it. So they're eligible both for Medicaid, which is people with low incomes, and Medicare, which are people who are either disabled or aged, right? So 65 and over. So it's people who fit the Venn diagram, the overlap of that community, or who this special, these dual special needs plans are really targeted to in trying to provide their needs. Now, it's not just the DSNP plan that is there to help provide income, or to provide, coverage for health insurance needs or health needs of people with low income. There's actually 4 government programs that are set up to help people with low income cover the expenses to make sure they can get the help they need. Kind of a great, very holistic and way of the government to really trying to be providing the needs to this special population that's an at-risk population. That unfortunately is just growing and growing. But there's the 4 areas. Now, the top and bottom on this little diagram are the 2 we've already talked about. Medicare, which you all probably understand pretty well, being Medicare agents, and probably most of you AHIP certified, and you've been through all that training. And the bottom, Medicaid, which you may not understand quite as well. The other programs that people oftentimes get confused, which are separate programs that help determine a number of things, is the low income subsidy, which we are more casually familiar with, but is administered by a different part of the government altogether, has no relationship to Medicare and Medicaid eligibility, and is a separate program just managed by the Social Security Administration to help with their prescription drug costs. That's all the extra help, which is a proper noun, by the way, and the low income subsidy, or LIS. That program is really set up to help people with low income with their prescription drug costs. Really got born out of the whole donut hole years of when the donut hole was, so huge we could drive a Mack truck in it, and people were hitting it in September of every year and then skipping their meds till January and having all kinds of health problems. The low income subsidy really came in and helped that at-risk population, but it's unrelated. Now I'm going to go through a little more detail in a minute, but the big one that we're going to talk a little about today is the Medicare savings plans, which for those of you who haven't sold in this market before, I'm really dipping into your AHIP training. And this is where the alphabet soup and the acronyms of CMS really start coming through, because this is where those plans that are Medicaid money, so they're part of Medicaid, which is why if you notice the colors, both of those are yellow. They're funded with Medicaid money, and they're there to help offset the out-of-pocket expenses of Medicare, which is why the name is Medicare Savings Plans, MSPs, which is kind of confusing because it's Medicaid money for Medicare out-of-pocket costs. It's administered by the Medicaid groups of each state. So each state calls these things a little bit different in their vocabulary than the CMS alphabet soup that we'll talk about today of QMB and SLMB and QI and whatnot. Those plans also distinguish a big difference that you've seen in the industry the last couple of years as companies like Molina, and we're one of the big proponents of this, we actually have created plans for the partial eligible dual community versus the full dual eligible community. And we'll talk about that coverage and why we've done that, but it's their level of Medicare savings plan that determines which one of those Medicare plans they're eligible for, Medicare dual special needs plans, right? So which DSNP they're eligible for, and the benefits are adjusted accordingly to the needs of each of those populations. And that's why we're going to the extent is that we found that, you know, someone who's on a Medicare savings plan but doesn't have full Medicaid benefits, because that is a very real possibility and happens that they make just enough money not to qualify for the state's Medicaid, but they don't make enough money that the government thinks they should be able to pay all of their Medicare expenses, and so they qualify for one of the Medicare savings plans to help them cover those costs. So works pretty good, but the plans are different because we know their needs are different. So that's kind of how the pieces work. Now I'm going to step through each of these four for a few minutes just to give you an idea. Now I'd love to take any questions you might have as we go through these. I know I'm moving hard and fast today because I'm wanting to stay within our time today, but I also want to keep your interest, and I want you to hang tight through some of these definitions, because I tell you, the first time I was selling and I had someone come in and I had done my AHIP, I had a practice that really didn't focus on low income, and they started talking about that they were lower income. I started scratching through the archive in my brain of my AHIP training of saying, oh, okay, well, now if they're eligible for that, I know they get extra benefits, I know they get different things, and I started digging through it. So today I'm hoping just to give you a kind of a primer on all of those topics, so that once you get in that situation, if you're not going to target this group, which by the way, we've helped a lot of people build entire agencies off of targeting exclusively this, because this group is so strong to people who are loyal to them. They are much more resilient of staying on a plan because the benefits are so much richer, because we as the company have more money to fund the benefits. And I'll show you some examples of that in a minute. But let's talk about these four different areas again, just so you understand them. So low income subsidy, I already hit the basics on it for you. Social Security administers it. It's not related to any CMS eligibility. It's not related to any state eligibility. So, Medicare and Medicaid status has no impact on their LIS status. It's strictly their income. And there's a guideline every year that kind of changes the dollar amount for their household and everything of what level. There's 4 levels that you get. And so at each level, you get more help. So level 1, and it's kind of reverse in my thinking, but level 1 means everything is paid for you for the most part. So you'll have virtually no expenses for your prescription drugs. Remember, this is a prescription drug or a Part D benefit only, and it covers those expenses associated there, like co-payments, co-insurance, the deductibles, helps fill in some of the things in the I don't call it a donut hole anymore, I call it the pothole, the prescription drug pothole out there anymore, because they can still get into that. So that plan is separate. Oftentimes it gets confused because most states automatically enroll all of their Medicaid eligible people who are also eligible for LIS, they auto enroll them. So to your clients and to you as a broker, if you've gotten into this space just a little bit, oftentimes LIS and dual plans get treated as one, or LIS and Medicaid, everybody thinks they're one program, because the federal government and your state governments want them all enrolled. They want those costs, there's budget money for it, they want it to be used, and so they auto enroll them in both programs. So it feels like it's one program because they only did one application, but it's actually a separate program. You can get people enrolled differently. If you have people who make a little too much for Medicaid, you can still go get some help at levels 2, 3, and 4, which just progressively work up on them covering a little more of their expenses up until they're off of it, where they'd cover 100% of their prescription drugs. So LIS is that one, isn't affected at all by Medicare and Medicaid. CMS confuses that even more because we have an SEP for people who are, and what do we call it? Dual LIS SEP. In reality, they still are 2 moving parts, but they made one SEP with the name on it. So we'll talk about that here in a minute too. So the second one that we have on there I want to talk about is that dual special needs plans. This is a program that is funded both by state and federal money. It has additional money from a traditional MAPD plan because they realize this is an at-risk community who has higher than normal medical needs due to physical limitations. They aren't able to, oftentimes physical and mental limitations, aren't able to make enough money to cover the costs themselves, and they want them to see and get the help they need. Obviously, this is a big section that we deal with a lot of behavioral health issues. Like I said before, we deal with a lot of addiction issues and follow-on health consequences of drug abuse and other addiction problems. Besides all of, in my opinion, the obvious ones of families who have Down syndrome children, or Down syndrome adults, aunts and uncles, people that they're taking care of, or other physical or mental disabilities like autism and other real-world situations that impact a lot of individuals and family. These plans are really geared, and the idea is that those funds come together so that that individual really has a $0 cost to get medical help. And it's done by Medicare if they're fully eligible for Medicaid. Medicare is the primary payer for all their medical, and Medicaid is a secondary payer. The programs are tailored to fit, hand in glove of covering all their expenses. So all the out-of-pocket expenses, all that. So they don't have to be worried about, do I get this test? Do I get this procedure? They can improve their health and they can go with it. So it's very watched over and managed. There's a standardized model of care to help do it. That's where our health risk assessments are really being driven from, of why we as brokers are able to be paid by completing HSAs, is because we're helping that model of care. We're helping them get the help they need by putting case managers in place, which is another big difference here between DSNPs and traditional Medicare. And so is that they have usually it's a professional, nursing professional who is assigned as a case manager to help them navigate getting their services, changing, if their oxygen provider is not being reliable, they can find another one in the area and help them do that. That's in the plan. If they need help finding a specialist for a certain case, they can do there. If they have issues trying to navigate the silos of a big corporation of 13,000 employees, they have case managers who can help in that DSNP space. So the DSNPs are that Medicare portion in most cases. Now there's a FIDE SNP and some details that if we had 2 hours today, I'd cover no more detail. It kind of merges Medicare and Medicaid into one plan, but the Medicare portion for someone with low income is to see if they're eligible for a dual special needs plan. We've talked about Medicaid. That's a state-run plan that has some money from the federal government, but it's traditionally a lot of the state government. The state gets to define it state by state. Those of you who have worked in California know that it's called Medi-Cal out there. I think it's called Apple Care in Washington. All the states kind of brand it differently for Medicaid, and usually Medicaid in all states is eligible to people of all ages. Some states keep it for adults because they have other CHIP programs and things for children under 18, but for the most part, it's eligible to everybody. And the population we're talking about today are those who are also on disability, so SSDI, and 24 months after someone's put on SSDI, if their situation is not something seen as a short-term curable situation with their disability, they automatically get enrolled in Medicare. And we all know that, but they just get put in A and B. they need help getting navigated over into a plan that can help them cover all the rest of their expenses, right? So Medicaid is eligible for everybody. It's funded in multiple places, governed by the state. The last section we're going to talk a little about on these, remember our 4 circles in that diagram? The last one were these Medicare savings plans. Now, I'm just going to say again, kind of what I said before, is that these plans are put in place with funds from Medicaid to pay for out-of-pocket Medicare expenses. It is a bit of an alphabet soup. So here are the names of the categories from a CMS perspective. Every state calls some of these a little different. They'll sometimes have 2 or 3 things that qualify as, say, a QDWI, different things. And I've got a table in this slide deck that you can refer back to that gives you the exact definitions of each. I've done this enough. I kind of have a general idea. If someone's, QMB plus, so if you see that there's pluses and not pluses on some of these, is that if they're QMB plus, it means they're fully eligible for all Medicaid. That's what the plus sign means. So they're qualified Medicare beneficiary, which means they get all of their out-of-pocket expenses with Medicare also paid by Medicaid. Plus, they're full Medicaid eligible. I know, isn't this an alphabet? So I see Joe laughing at me, stumbling over my Cades and cares. But the QMB plus lets them have all of their premiums, co-pays, things that they would have to pay out of pocket for Medicare covered, plus then the secondary payer of full Medicaid and all of the additional benefits that some state Medicaids provide additional dental. We have in one of our states with one of our plans that's on our Flex card it's $5,000 of cash on a MasterCard, and they have almost $5,200 of Medicaid dental benefit that they can go use first. So if they go use their Medicaid benefit, they can use their Flex card to do it, and in 1 year, all at one time, they could go get $10,000 of dental work done, no cost out of their pocket. And so there's lots of options here if you understand how to use, help your clients with these programs. Now, these other sections, these other definitions we'll go through on the table in a minute that have different parts of their Medicare out-of-pocket expenses covered by Medicaid dollars. Like SLMB, that's the next one that most everybody talks about. SLMB, or specific low-income Medicare beneficiary, is someone that has their Part B premium paid. That's it. A SLMB Plus is someone who has their Part B premium paid plus full Medicaid benefits. So two different classifications. So a partial eligible and a full eligible. Then these others we'll go through in a minute. So if I go back to our diagram just to tie this all together for you here and what we've talked about, just to remind you. So we've got the Medicare and Medicaid top and bottom. Usually someone on low income, that's the first thing you want to check is say, if they're full Medicaid eligible, it's very easy to get them on a full DSNP that will really take all of their medical expenses to about zero, plus give them a wealth of additional benefits more beyond the basic 4 additional benefits. A lot of our plans have pieces on them that allow them to get not only the chiropractic and acupuncture and podiatry that we're starting to see on a lot of the traditional MA plans, but we'll also have an increased number of meals that can help them, increase transportation, increase dollars for OTC, things that are improving quality of life and independence. You'll also see that on all of our plans this year, not quite all of our plans nationwide, most all of our plans nationwide this year, I think all next year, will include a service called Papa Pals that allows these people who have limited resources to have someone come and help them with household chores, help them come deal with loneliness. Most of our plans have about 198 hours of services. So that additional benefit makes a big difference when you get them on a DSNP plan. There are these savings plans that allow people who make a little bit too much money to be full Medicaid eligible, but still get help with their Medicare. There's plans now that provide this same level of benefit for them. And they are full DSNPs. They're just not fully eligible for one plan versus the other. So knowing the difference there makes a big difference. And then obviously low income subsidy or extra help is a different category altogether, but is fundamentally a part of your conversations with them. Obviously we don't get commission for that as brokers out there in the community, but you've got to be familiar with what their LIS and their LIS status is to help them understand all their expenses. So it makes a pretty good picture of providing great support for these low income beneficiaries who have an increased or a higher need for medical services. They're an at-risk population. The states want to do it, but as brokers, one of the reasons we want to look at them to grow your business, if you want to have great work year round, because again, we're going to hit SEPs and election periods here in a minute, you can be enrolling these people year round. You don't have to wait for AEP for your big block of them. Matter of fact, we normally see a lot more enrollments the rest of the year than AEP for these groups. As you build relationships with these groups and you get into some of the facilities and that, it's a constant stream of referrals for you, a great way to grow the business. And I've seen a lot of agents who, back in my days, I always called it giving birth to a new agent. Someone who is just licensed for the first time, they're looking, where can I start building my book of business? If they learn this space and they go build those relationships, they have a constant year-round feed of generated leads that are coming to them, and a community that would appreciate any service they want to give and reward that with having conversations with people who can help them. So great things for business growth in that area. Here's a little table. It's not real clear, probably on the display here, especially minimized as it goes across to everybody, but it'll be in the deck that we'll provide John for you guys to be able to download. It's a great quick definition of all of that alphabet soup. And if you're wondering what type of expenses do Medicaid Is Medicaid willing to pay for on the out-of-pocket expenses with Medicare? Well, that QMB, like we said, it pays everything that Part A and Part B doesn't pay, from co-pays and co-insurance deductibles. And if they have the plus sign with it, they then also have the secondary payer and all the additional benefits of Medicaid, because some states have additional transportation for kidney dialysis services built in. Some of them have additional transportation. Like I said before, some have additional dental. When they have full Medicaid benefit and Medicare benefits, they'll typically be labeled as a QMB plus or an FBDE that we'll talk at the bottom. The SLMB pays for their Part B premium only. SLMB Plus pays for that Part B premium and full Medicaid benefits with all of their additional benefits. QI pays for their Part B premium only. Now, if I sound like I'm repeating myself, it's not deja vu. The two have different labels and different qualifications that the states can use, but the benefits are exactly the same. So they get that Part B premium paid for. And as you'll notice, there's no QI Plus. So QI is for people who don't qualify for Medicaid as a secondary payer, but they do have other reasons that they're qualifying for a Part B premium help, like an SLMB, but the SLMB has different qualifications. So similar benefit, different programs. And again, your state, every state you focus in, you kind of want to learn the vocabulary, because some states will call, I chuckled at this because we have this great big spreadsheet for our enrollment teams and our sales teams to understand this state by state, because in some states they'll have 4 different programs that all qualify in CMS as SLMB, and all the benefits the same, but they qualify differently. So the state calls it specialty waiver for Medicare monthly out-of-pocket expense, or they'll call it something like that. But the states want to have their own acronym. And I remember I was working with one state, and they were asking us exactly. They were getting ready to roll out some additional help for low incomes, and they were asking us some of our guidelines of what we followed. And we said, well, CMS's guideline, and they looked point blank at me. These are state officials at the highest level in their legislative office. They look at me and say, we don't care what CMS and the federal government do. We are, put your state here, and we want to do it our way. So the states will label those a little different. And if you need help masking any of that, please contact Joe or any one of our local reps, as we do have people out in the field in each market there to help you, train your staffs, help make introductions, provide materials, marketing support, all of that kind of stuff out in the individual markets. We keep working down. QDWI is another one that there's a different set of qualifications, but you could be QDWI and you get help paying your Part A premium. So in other words, this is a very niche play for people who didn't qualify for Part A. They didn't get their 40 quarters, and in a lot of cases, if they're not an immigrant, they didn't get their 40 quarters because of health issues. They weren't able to work full time to get their 40 quarters. And so there are programs within Medicaid to pay that premium for them. And by the way, if someone qualifies for any Medicare savings plan or Medicaid, the late enrollment penalties, the LEPs, are all waived. And so while they're eligible there. Now, if their income fluctuates a bit, say you've got someone who's low income, they get some type of inheritance that has an ongoing income aspect that, every state has their own clarifications, would throw them out of being full Medicaid eligible. All of this type of stuff gets reassessed as they look at it as well. But anyway, then in the last category is a giant bucket for every state to create the programs however they want. And so get to know your state, get to know it. There's a lot of them that will fit this FBDE category, or the full benefit dual eligible, which just means they're eligible for all the benefits of Medicaid, and they get that secondary payer, and they get all the cost sharing covered. So an FBDE categories, and again, the states may have 3 or 4 different buckets because they're trying to categorize their Medicaid people in different groups to address certain populations with the other programs that they're combining with. So get to know those. Those are great. Those are great alphabet soup for you to do. So in quick summary, some dual plans. Now let me get specific about selling a dual plan, and I use that casual terminology, a dual special needs plan, MAPD plan, because they are MAPD plans. All of the rules and compliance of an MAPD plan apply to a DSNP for enrollment, for eligibility, for all of those things, for commissions. They pay out just like every traditional MAPD does in commissions. and programs like that. But there's a lot of different styles of plans out there. Some plans include all of the eligibility categories that we just talked about, our alphabet soup. Some address the needs of those who are only partially eligible, who do not have Medicaid as a secondary payer, and those plans are adjusted. In Molina's case, a lot of our partial eligible plans just lock down that they can go see their primary care provider for $0 and their specialist for $10, instead of dropping off like a lot of the old lookalikes or even some of the full all dual plans. If you don't have the plan covering it, then they are up for 80-20, which 20% of a specialist is probably a lot more than they have in their budget. So you want to make sure they have plans that really fit their needs. And then there's plans that are geared for people who have full benefit from Medicaid, and we're able to reallocate that money down to richer benefits. And so you really want to kind of know what's available in your market, what's there, and even in our portfolio of products nationwide, we really do try to custom tailor them to the different markets, and try to have things that make sense in the markets, and you can see why we have a partial Medicaid eligible and a full Medicaid eligible. And hopefully after today's at least orientation to these topics, you have a general reason and understanding why, and that you can be conversant on the topic. We could drill down any one of these topics and go for quite a bit, but again, I'm hoping to give you just that overview at the top. We can see what it is. Let me show you a couple quick examples in our last few minutes here, then I'll open up for some questions. Let me just show you two plans side by side. We talked about this partial eligible plan versus a full eligible plan. Now, I think all of you, I hope you, when you came here, you've been pleasantly surprised that you haven't had to sit here and pound down a highlighted benefit sheet like we've done all fall in a lot of ways. And I hate even bringing these up except to illustrate points like I'm doing here. So I'm not going to walk you down through this, but on this, these are our two plans offered in Utah this year. I'm based in Utah. I know these plans. That's kind of why I pulled these two, and they illustrate pretty well the differences. Now here, some of what I've told you is a slightly different in reality as it hits the street. So the plan on the left is our plan. If you look up here at eligibility, see if my, oops. I'm going to jump back a slide. This plan here, if you look up here where my mouse is kind of circling or hovering around, you'll see those are all in Utah categories that qualify as full Medicaid eligible DSNPs. So if they're QMB, QMB plus, Slim B plus, or FBDE, they can get on this plan that zeroes out everything because they've got Medicaid as the back end provider. We keep a max out of pocket on that because it's such a minuscule people who can get closer because they don't have any out of pocket expenses. Medicaid really covers it, hospitalization, all the things that would normally do that. So we reallocate that money into other nice benefits like Silver and Fit, the 2 hearing aids per year, 0 expense to them. 192 hours of that Papa's Pals that we talked about, of having companionship help, yard work help, house cleaning assistance. Sometimes I think they let them now do transportation if they just need someone to help run them and they don't want to call an Uber or Lyft that the plan will pay for, but they can leverage that. We provide them 112 post-acute care or on these plans, if their case manager deems that meals are appropriate for their situation. We did a lot of this during COVID. People who just didn't, high health risks, didn't want to get out in the community. We were able to get their meals turned on and get meals delivered to them. So a lot of meals there for them a year. Both these plans have our My Choice Flex card on them that allow us to put cash on a MasterCard, which eliminates the need for a provider network or a limitation of coverage or services. If they go to a dental provider, they can negotiate as cash, pay for it with the MasterCard. They don't have to say that, oh, you take Molina or anything, because it doesn't matter. They're not doing any billing. And this plan will have $4,000 loaded immediately on when the plan's issued for dental that can be used at any dental provider. It's all governed by their Visa account, and just saying that they've registered that as a dental provider. It'll go through and come out of that bucket on their card. Same exact card we use for vision. They got $300 a year on that full plan, $410 per quarter for OTC and transportation lumped together. So if there's someone who has a high need for transportation, a lot of dialysis, a lot of no support network around them that can help get them to the doctor, the pharmacy for their appointments, they could just use that, and they can use it as cash with any public transportation. So if they want to go buy their monthly bus pass, they can buy it. They can ride the bus anywhere they want to go. If they have a light rail system, you can buy the pass, use it anywhere you want for that month, where it's going. If you don't need transportation help, then you've got all that money to go spend at your local drugstore. It's OTC products that are CMS approved. So it's got to be one of the drugstores, and most every drugstore anymore is having HSA and FSA and CMS approved lists in their computers. So they go through, it automatically allocates what of their purchase goes to that card, and then they just ask them for payment for the rest of their purchases. That's a lot of money. That's $6,900. If you add that up together, we got $4,000 in dental, $4,300 when you add the vision to it at any provider. Again, you want your 2 eyeglasses and exam for $69.99. You can use that for that if you want to, and still have a lot of money left for another set of glasses if you want them. Transportation, this is another $1,640 that they've got that will be on that card. Now it's a quarterly benefit, so the first 2 are loaded immediately. This one, the first quarter is loaded. At the end of the quarter, it's a use it or lose it. It gets refreshed to the total amount for the next quarter. We also have a food and produce benefit, which is $60 a month on this plan, which, there again, we've got another, what's my math on that? 60 times 12. We've got $720 that's there for it. And then they have other benefits that the plan provides that there's another $150 a quarter, things like service animal supplies, genomics testing not covered by Medicare we found great help with having that testing done to help establish behavioral health plans of care. Lots of neat things that come with that benefit. Compare that to our special needs plan on the side. You might see, depending on their LAS status, they might have a little premium or PC or prescription drug costs, but for the most part, all these other costs are very low. And then you look at all these additional benefits, and they actually bump up. They get $3,600 a hearing aid allowance both years. So they could actually upgrade from the standard, $1,500, $2,000 hearing aids of the 10 providers that we provide. Basically, here they now have money if they want to put that towards getting a Bluetooth set of hearing aids. You come down here, you'll see their dental services, MasterCard, same way, $5,000. Vision, $500. OTC, $5,000 a quarter. Food and produce, $85 a month. Our benefit a year ago was $35, and I was presenting to a team of brokers, and the woman, the principal of the agency, was just sitting there, and I could see tears starting coming down her face while I was presenting. I thought, man, my presentation must be bad. I'm driving her to tears. And she'd been asking some clarifying questions around this food and produce, and I asked her, I said, everything okay? She goes, you don't realize we have to advise my mother-in-law, who won't take any help from any of us, and you just doubled her food budget every month. And she says, you don't know what a change in her life this is going to be, So amazing impact on perspective, as we go. But this is for our partial eligibles of SLIMB, QI, and QDWI in that state. And again, those are all state-by-state plans on how they do. In closing here, just want to hit the same thing John hit closing earlier, is don't be afraid of this market. It grows your business. And there are a lot of election periods related to this group that lets you enroll people year round. The one SEP that everybody talks about is the one that I have kind of illustrated at the top here, which is the dual/LIS SEP. And that means anybody who is dual eligible could change their plan once a quarter based on signature date, not on effective date, signature date, for the first 3 quarters. And then they could change again in 4th quarter using AEP. Because, as you guys all know, SEPs, people are eligible for all of them. So I put this list on here on this slide. I always just remind people that there are 2 others that affect this population that we're talking about, is that if they're new to being dual, so if they're newly awarded their benefit or new to LIS, again, they merge the 2 a lot in these, that's a different enrollment period, any month of the year. It's not the 3 quarters. It can be used through 4th quarter around AEP. So a lot of our agents who are still selling here towards the end of the month, or people if they're new to just being awarded their Medicaid benefit or LIS, they can use that. Then there's a second one if they ever have a change in their benefit. So if they move from LIS level 2 to level 1 and their benefit with their Medicaid, they all of a sudden go from a partial to a full Medicaid, that eligibility period is not the same one at the top. So there's multiple SEP periods, and there's a lot of others that are all the standard ones that you can use with the traditional, are all eligible here because these are traditional MAPD plans. So with that said, I'm trying to keep our close here at the top of the hour. Got a minute over. I do want to open it up. I haven't seen any questions come through on the chat. John, have you seen anything come through that I may have missed?
No, we seem to be pretty clean here, Jim. I want to thank you because one of the things I wanted you to emphasize was the special election periods and the draw that we have because of that possibility. You know, we speak of lock-in and everybody's exhaling with, okay, let's wait till next year. Well, next year's tomorrow. Next year's today.
Next year's tomorrow. We get so many people who call this stretch between December 8th to December 31st blackout. And I always laugh and say, well, I have a black shirt on and Joe has his black shirt on today, but it's not a blackout. You can still be enrolling. If you brought up some of the disaster SEPs that are open. If someone couldn't enroll because of Hurricane Ian, those SEPs are all still alive till February. That's affecting everywhere from Florida all the way up to Virginia. We've got droughts in California and in Texas that are possibilities. So be creative. Don't be afraid to ask. Call John, call Joe, call me. If you need help brainstorming, you got someone who really needs to be on a plan, let's get them on, and we'll find an election period that works for them.
Awesome. I thank you for that as well. So what I'd like to do now is take the control back for just a moment. We'll finish up with just a few slides. And I'd like to remind people that we do have a number of the tools that you can use to market this. And it's one of the reasons why I'm fond of visiting with the folks from Molina is because of some of the support they put into not just the explanation of these benefits, but how we find people to actually talk to them about programs that they qualify for. And I thank you for that. So I want to pull this back really briefly and then go into why do you want to do this with Premier? Well, we'll help you contract with organizations electronically. Molina's contracting process is very simple. For those of you that haven't contracted with a Medicare Advantage plan, obviously the certification on an annual basis is a big parameter of that, but we want to make certain that we do everything compliantly, but in as timely a fashion as possible. So in the brave new world in which we exist, we do things electronically. We do also offer discounted errors and admissions coverage to a qualified agent. What makes you a qualified agent? Well, you got a contract with us, but this is a program you own. You're not added to a blanket policy, policy for just one program, and you have to scramble to satisfy this requirement with other carriers. Premier is huge, but we don't have every company in every area. I don't know of anyone that does. We want to make certain, however, that we help protect you and your financial wherewithal through this type of coverage. We do also offer discounted continuing education courses to make certain your license stays in play through our association with WebCE. And you actually have an opportunity to add to your own benefit package through a modified guarantee issue disability income program that you write on yourself and are paid a commission. Much as where today's presentation is being recorded, past presentations have been as well. I mentioned at the top of the presentation, they're available on our website and on our YouTube channel. But when we talk about the dual special needs programs and a lot of the special requirements that come with it, being knowledgeable on the different levels of assistance and things of that nature, we also have programs out there that are helping you address this population and find them. A lot of this is the let's shake hands and kiss babies technique, because you're out in the community and making yourself available as a subject matter expert. So we have programs out there talking about how you visit with provider community, with faith-based organizations, being a center of influence in your target market. And I think you'll find them very, very helpful, particularly when we pursue this population. One of the things I really want to emphasize, is the availability to our contracted agents for access to Medicare Center. And this is the program that we have that is a phenomenal electronic device that gives you a single login for multiple quoting engines, allows you to make the side-by-side plan comparisons compliantly because you've collected the scope, you've recorded your calls, and they're all being stored for that 10-year period if you sell them or not. So it's all available to you without cost as part of that. We do also offer a PURL, a personalized URL. So you have a microsite that comes to you as a contracted agent through our organization that gives you a presence on the web. You're going to link that to any website you may already have. There's also a contact management system within this program that includes switcher tags. So it shows your book of business, folks that are most vulnerable for change. And that gives you an idea as to how you prioritize your annual reviews, because, hey, with this, you have all of your prescription information stored on it, and it enables you to do things properly and quickly, efficiently, and gain business because of it. The Lead Center program is a fairly new addition to this tool, and that allows you to purchase leads through this system, either through a live transfer or through a lead that's placed in your contact management system. They're all cycled through that, and it gives you then the power to budget for different leads and control when and where they come from and at what cost. There are other resources within the tool as well that helps you be more efficient at your selling tools. Some talking points. I don't use sales scripts. I hate that terminology. But different things that can help you be more effective in dealing with the people that you're actually speaking with. The program is available as a mobile application as well. And in the vernacular of J.J. Walker on television, it's free. So it doesn't cost you anything as a contracted agent with our organization. We do, however, also want to make certain that you're aware of all of the compensation that you're entitled to through your sales efforts. And while Medicare Advantage plans and PDP programs, max comp is set by the government. Most carriers lay that out, as does Molina, where you're going to get paid as much as possible up front. It eliminates any type of incentive program, but some of the other plans that you may offer as a door opener or for whatever other reason, they may have incentives that help you qualify for trips with that carrier and through incentive programs through our organization as well. And that includes the re-announcement of our sales trip, which you can qualify for in 2023, going to the Riviera Maya. As a non-swimmer who is a little overweight, I'm allergic to harpoons, so I probably won't be on that trip, but I know many of you would enjoy taking part in it. We do help get you in front of people. We do make contact lists available for you for programs that are available to cold call. You never do that for MA or PDP programs, but you could for a dental program or final expense or maybe even MedSup should you choose to do that. I referenced this before too, how we can make you effective within the community. So maximizing the return on your retail marketing investment. If you worked in a Walmart or a different pharmacy, by golly, don't let that end on December 7th. Make that a year-round opportunity by working that situation throughout the year. Approaching faith-based organizations and providers where these are folks that really help identify our target market. We have programs that can help you there too. There are different carrier-generated leads upon occasion, but this is a reminder for us to really invest ourselves in creating a relationship with agent managers in particular markets, because in most cases, the carriers, well, that's who determines who gets leads from different carriers if they are available. So it's one of those quid pro quo situations. Throw a little Latin at you. You scratch my back, I'll scratch yours. Don't go to a carrier and say, hey, what do you got for me? Go to a carrier and say, hey, this is what I'm doing. How can you help me better our efforts? The whole looking for a handout, that's a good way to find the door on the way out. We do offer internet social media leads as well, direct mail support. I'll go into detail on the Lead Center in just a little bit. A really cool T65 locator, and then a reminder for the referrals. Jim mentioned how this population is a community, and let's face it, we tend to associate with people that are like ourselves. For some reason, Mark Cuban doesn't return my calls here in Dallas. We're kind of in two different social stratas, we'll put it that way. But the folks that qualify for these programs tend to hang out with the people that qualify for these programs, or their family is. It's a great way to work through and take one lead, blow it up, and make it work for you. And that program kind of walks you through how you can do that without appearing like Herb Tarlick on WKRP in a plaid jacket saying, hey, you want to buy a watch. The co-op for the mail program is based on production, but it drives down the cost of a regular mailing, and you can qualify for both health products and final expense programs. And we do so through vetted vendors where the systems they have in play help you get the response as quickly as possible. And we have oversight on the letters that are going out, so we keep them on a compliant basis. We also have an access to deliver programs, direct mail responses to you at discounted prices through one of our partners that enable you to fill holes in your schedule as well. Now, these prices will vary from area to area and time to time. It's kind of a supply and demand thing, but a great way to fill your schedule and make certain that you have the constant activity you need to be successful. Internet lead programs, there's one for final expense, and then there's one for MA through Facebook. One of the things that we've discovered with internet leads is they're a microwave type of activity. You can get them quick, but they can go quick. I had a lady friend, an agent, who got a lead that came into her at 2 o'clock in the morning. She's an early riser, got up at 6, and that person had already gone someplace else, thinking they didn't get a fast enough response. So one of the things we want to be aware of is, hey, you can get a lead quick, you got to take care of them quickly as well. Medicare Center's Lead Center, this is that program I mentioned where you can check in, you can get live transfers, get leads put into your contact management system, a great way for you to rectify a balance between your budget and the lead flow that you need. You can turn it on and off as you like. It's a really great campaign that we've had great success with in many markets, and something that I would very much urge you to investigate. And every now and then, there's even a sale on some of these leads, as there is right now, 30% off. The T65 locator is a great tool for you to identify people in a particular area. You download it to your smartphone or your desktop or your laptop. You register, they find you got a contract with us. Once again, JJ Walker, it's free. You can put in the parameters and it'll identify people in an area. This is something we need to be careful with Medicare Advantage and PDP programs, but we find many agents will layer appointments in a particular area. And if one cancels and you have a space in there, how do you fill it? Well, this you can plug in and you can identify people in an area, and it may give you an opportunity to door knock with an opening program like dental. Don't door knock for MA or PDP. Good way to lose a contract or two there. But it's a great way for you to fill the area and create marketing activity for yourselves. Once again, that referral program, don't limit it to just the sales process. Prospects are great to ask for. Who else do you know? But it's also an area where you can go back to your book of business, utilize that contact management system, and say, hey, I've got a great new dental program that's rolled into your area. Do you know of other people I can help with that? What you get a lot of times is a response of, well, I know one person, you're talking to them. A great way to bind additional business. And we see through different studies that the more product you have in a house, the higher your retention and persistency is. A great way to make certain that we are helping you grow your seller rate, which is your renewals. So all that said and done, we do all this because we want your business. We want to be referable to you as an organization, and we thank you for that opportunity to do so. And so these are programs you can put in play really quickly. You can make certain that it's part of your personal marketing plan, implement it, and we have programs then that can help you be successful. But it's one of those situations of, okay, we're a few days before Christmas. Oh, I'll wait until after the holidays. Don't procrastinate. Do the old John Wayne bit out of the movie The Cowboy. Slap a piece of bacon in that biscuit, saddle up, let's ride, because we're burning daylight. We got things to do. We can still get an effective date of 1/1 with these programs now if we're ready to move forward. So at this point in time, I'm going to check and make certain that we've covered all the questions that are out there, and it appears that we have. So for those of you that have done business with Premier in the past and are viewing this presentation, I thank you for that business. I sincerely do. I hope we can deepen our relationship through the use of programs such as the dual special needs plans offered by Molina. And I thank you for investigating that a possibility. For those of you that haven't done business with us in the past, thank you for looking at us. We hope to be a resource for you moving forward and grow together. But most of all, at this point in time, I want to thank you for sharing your most valuable resource with us, and that's your time. A great time now to ease off perhaps a little bit. Some folks are. You need to rest, but I thank you for the investment of the time that you've made with us here today. And until we are able to visit again, I wish you good selling. For our friends at Molina, Joe, Jim, thank you very much for coming on and helping with us today. We look forward to additional future activity and watch for additional exciting information from us concerning Molina on some of the systems and some of the things that we can do together. Once again, thanks so much, and we look forward to speaking with you soon.